Yeah,
I think it's already time, so let's
yeah,
just start.
sure. Um, yeah, it's another Sunday. It's unfortunate we didn't have one last Sunday, and but here we are. David, today we're going to have pretty short case, and there will be some learning at the end from you, from me, from everyone else. Um, so let me jump straight to the case, and so for today we have 48 male who presented to the hospital I work with vomiting blood.
Okay, so yeah, again, we didn't have a session last weekend, and yeah, so I think my brain is already rusted, but now there's another thing. When Joseph says today's case is a short case, you should know that's a very difficult case. And most likely you probably won't get the diagnosis right, but let's see. So vomiting blood, I believe, is a complaint that almost all of us have come across, maybe even if it's not in practice, but at least when you are a medical student, because wards are filled with patients with hematemesis. So it's a very broad complaint, and the very first step that I will take is to clarify and be sure that really I am dealing with hematemesis and not anything else. Because someone can come to you and tell you that they are vomiting blood, and you find out that the source of the bleeding is actually the respiratory system rather than the GI. So that will be the first step to clarify if I'm dealing with vomiting blood or something else. And so I'll try to differentiate it from hemoptysis, for example, because someone can cough up blood, and then if they swallow that blood, or let's say they have a nosebleed, when someone has a nosebleed or a tooth extraction, they can swallow the blood, and a small amount of blood for some reason can irritate the stomach and lead to vomiting. And so if someone vomits and they see they vomit blood, that's a very scary complaint. So they'll come right away and complain of vomiting blood. So that will be the very first step to clarify if I'm dealing with vomiting blood or something else. And then if I'm sure that I'm dealing with vomiting blood, then I'll go down the path of upper GI bleeding, which has many differentials. So I think I'll discuss that after hearing the HPI.
Yeah, that's pretty nice to start. And so let's go to the HPI. Um, so he started vomiting fresh blood, and he presented to our emergency after a few hours. He estimates the volume of the vomiters to be approximately 250 cc's, and he says this is the first ever episode. He has never seen something like this previously. A day later, he passed a false smelling Bactari stool, and it was associated with easy fatigue, palpitations, dizziness when standing up. But he denies autoalimentation, abdominal pain, abdominal distension, weight loss, painful swallowing, gum bleeds, easy bruises, constipation, or diarrhea. And that's a very short HPI.
Okay, so first of all, the epidemiology. This is a 48 years old male, right?
Yeah.
Yeah, this is the first ever episode of hematemesis. So the patient has vomited fresh blood. So based on this HPI, I'll make that assumption that of course you made sure that we are dealing with vomiting blood. And so of course the volume that is reported here, the patient had one episode, I believe, and the vomitus was around 250 cc. And then of course he also experienced an episode of melena, and there are some symptoms here. So The symptoms that we see are the complication of upper GI bleeding because the patient has lost some blood, so the effective circulating volume is down, and so the patient is experiencing fatigue, awareness of heartbeat, and he has some symptoms of orthostasis here, like dizziness when standing up. So that is a feature of orthostatic hypotension. So based on this one, in terms of the associated symptoms, we see that there is no altered mental status, which could be a complication of upper GI bleeding. There is no abdominal pain. Now, the absence of abdominal pain does not rule out things like peptic ulcer disease, for example. So I read that somewhere that up to 50% of peptic ulcer disease, people who present actually with hematemesis and the cause turns out to be peptic ulcer disease, about 50% can actually be painless. So I'm not exactly able to explain how that can happen, but I remember reading that. And then abdominal distension, you could consider things like for example, if someone is having clinically significant portal hypertension with variceal hemorrhage, another feature would be splenomegaly ascites, which can all be reported as abdominal distension, and then no weight loss. Painful swallowing, if we are talking about something local in the esophagus, like a corrosive ingestion, for example, with erosive esophagitis. But again, the patient doesn't seem to have any kind of coagulopathy, at least from other sides, no gum bleeds, no easy bruises, and then no constipation or diarrhea. Now, based on the HPI, what exactly are we dealing with? I think it will be helpful to assume that I'm dealing with upper GI bleeding, and that means anywhere from the oral cavity all the way to that part of the jejunum where the ligament of Treitz is. So those are the sites where it is. So thinking about upper GI bleeding, I'll just throw out the causes randomly. So it could be some, I mean, apart from the things that I've already talked about, tooth extraction, nosebleed, hemoptysis. So it could be local issues in the esophagus, for example, erosive esophagitis with corrosive ingestion, or maybe someone had an instrumentation like an OGD, which we did not get from this HPI. And then when you come to the stomach itself, we've talked about peptic ulcer disease, of course, in the esophagus and the stomach as well. Not to forget variceal hemorrhage, because you can have esophageal varices as well as gastric varices. And then peptic ulcer disease, um, and then, of course, gastric malignancies. This patient doesn't have a history of weight loss, but I think with the age of this patient, we haven't had any risk factors. So I think I'll entertain all of them. And then the history is not in keeping with something like a Mallory weight tear, because this is the first episode of vomiting and the patient is vomiting blood. So, and there are many other causes. So some of them, we also have erosive gastritis. We have some rare causes. So, for example, if you talk of things like Dulafoy lesion or enteric fistula, and many others. So you can mention more than 10 differentials of upper GI bleeding. But with the HPI that we have, I think with the HPI that we have here, for me, it's difficult to pinpoint that we are dealing with GI bleeding GI bleeding due to this particular cause, because all we see, the patient vomited blood, and the symptoms that followed seem to be more of complications. The orthostatic hypotension, palpitations, and easy fatigue, but no clues to the cause. So another thing I think which will be important is the medication history. So I believe when you discuss the past medical history, the family social history, so any substance use maybe will pick some risk factors for upper GI bleeding, because some medications, of course, can lead to upper GI bleeding. So let's see other components of the history.
All right. Um, so Liver system, there is no shortness of breath, no cough, no joint or pain or swelling. Past medical history is end-stage renal disease. On maintenance hemodialysis, he does 3 sessions per week through a fistula. And he also has hypertension, allergic rhinitis. The meds include nifedipine for hypertension, clopidogrel, and weekly erythropoietin. Family and social history is married. His first degree relatives are in good health, and he doesn't smoke, drink, or use illicit drugs. Yeah, that's it.
Okay, so and I see the past medical history. So the review of systems unremarkable, nothing contributory. With the medical history, we see that this patient is a patient with end-stage renal disease on hemodialysis through a fistula, and is also a patient with hypertension. Can I see the medications? So I remember clopidogrel, erythropoietin, and then nifedipine. Okay. Um, yeah. So with this, so the end stage renal disease on maintenance hemodialysis, could this be a signal, or is just something completely unrelated, uh, and therefore a noise? I think I'll just I do not have any particular pattern that I recognize here, that you have a patient on maintenance hemodialysis and then they present with upper GI bleeding. Of course, I do know that because this patient is on maintenance hemodialysis, and so during dialysis they do use heparin in order to make sure that the blood doesn't clot. But then could that be a reason for that this patient is having a bleeding abnormality leading to upper GI bleeding? I'm not exactly sure about that. About the medications, um, clopidogrel is an antiplatelet, and therefore, of course, when you talk of upper GI bleeding, it's important to consider even antiplatelet medications. So antiplatelets, anticoagulants, they are all, I think, maybe the risk is not exactly the same, but it's important to consider. But otherwise, as far as the stomach is concerned, I think clopidogrel will be more friendly than salicylic acid, that is junior aspirin. So uh, with these medications, erythropoietin, I know, especially if the HB raises above a certain level, it's more about uh, the hemoglobin is high, a risk of thromboembolic phenomena rather than bleeding. So with this one, so maybe clopidogrel could be a culprit here, but I'm thinking about the fact that the patient is on dialysis and heparin is used there, but I do not remember coming across or hearing about a case of a patient on maintenance hemodialysis and then having upper GI bleeding, and the causes or the risk factors turning out to be the heparin or clopidogrel for this matter. So I think I still haven't I still do not have anything tangible to clench on right now. So uh, the physical exam, and then we'll see investigations if we'll get any signals.
Yeah, sure. So let's proceed. Um, so general exam, he was alert and oriented. He was a febrile, was pale, but not jaundice, no lymphadenopathy, no lower limb edema. He didn't have any stigmata of chronic liver disease that we could see. His vital signs, pretty unremarkable: blood pressure 120 over 89, pulse rate 76, expected rate of 16, and temperature 36. He was saturating normally in room air. Abdomen, non-distended, non-tender, no organomegaly, and tympanic percussion. Respiratory system, CVS, neuro were all within normal limits.
Okay, so nothing revealing from the physical exam.
except that it was
Uh,
pale.
yeah, except so yes, anemia from the bleeding probably, but of course we cannot. Again, another possibility is this is a patient with CKD, and the fact that he's on erythropoietin, so the CKD could be another issue uh, leading to the anemia. But then, so another thing I think that I have not discussed so far is this patient is on maintenance hemodialysis. We do not know the quality or the adequacy, I should say. I think adequacy is a better term, adequacy of the dialysis that is having. Because one of the things that, of course, can cause gastritis is we've heard about the term uremic gastritis. So if the patient, if the dialysis that is having is not adequate, uremic gastritis could be a thing. But again, with uremic gastritis, we commonly see yes, they will present with vomiting and other symptoms of gastritis, but not commonly bleeding. But so for this particular patient, maybe apart from the medications that I've talked about as potential risk factors, maybe another thing is to consider how adequate is the hemodialysis that this patient is having. So that is another possibility on the list. Can we see the investigations?
Yeah, some few people joined. I think after we started, can you give them a summary?
Okay, so Joseph has been presenting, a 48 years old male who presented with an episode of hematemesis, about 250 mils associated with an episode of melena. And this patient had symptoms of anemia and some features of orthostatic hypotension. He had dizziness when standing up, he had palpitations as well as easy fatigue, but there is no abdominal pain, no abdominal distension. And on past medical history, this is a patient on maintenance hemodialysis 3 sessions a week. He's on clopidogrel, nifedipine for hypertension, and erythropoietin weekly. And on exam, he was pale. Otherwise, systemic exam was unremarkable.
Yeah, that's a pretty nice summary. So here are the labs. White count was within normal limit. He had an HB of 7.3. His baseline when we checked was between 9 and 10, so this was reduced. MCV 101, platelet 154, creatine 671, and BUN of 52 all raised. But his liver enzymes were normal. The PT was a bit prolonged at 15.9 with an INR of 1.29, also a bit prolonged. But the APTT was normal, RBG was normal, and hepatitis B, HIV, hepatitis C were negative. We also did an abdominal ultrasound, which was also normal.
Okay, so with these labs, I think I mentioned two possibilities. I mentioned two possibilities. So one of them being the medications, but of course that is that is based on it's just a hypothesis that I do not recognize any particular pattern, and therefore, if I hear, maybe I should say this would be my first case to say that as a result of hemodialysis, the anticoagulants that are used there, the patient presented with an episode of vomiting blood. But then clopidogrel, on the other hand, I do not have any specific details on the number of times it's associated with major bleeding events like these ones, including an episode of upper GI bleeding. But then another possibility was of uremic gastritis. And with uremic gastritis, I had some reservations that so commonly we do not see vomiting blood, but I can't say it's impossible. So, and so I was thinking about the adequacy of hemodialysis. So we see that I'm not sure, Joseph, I do not remember if you told us when the last session was. at the time you were seeing this patient and maybe at the time when these labs were taken.
Mm.
Because we see the creatinine here is high, the BUN is also high. So I think in my list of possibilities, I will consider uremic gastritis as a cause of this episode. And then, of course, we see that the bleeding indices also are also a bit elevated, although I should say this is very modest, because even so we consider when you talk about you see with an INR of 1.2 from an upper limit of 1.1, maybe not very significant. If we had something above 1.5, I think that would make us worried. So the bleeding indices are just modestly elevated. Uh, yeah. So based on these labs, I think I still haven't changed my mind so much. I still have the same differentials, but in addition to that, of course, I should again say that common things occur commonly. So so peptic ulcer disease, we cannot completely throw it out. Of course, we do not have any signal for variceal hemorrhage in this patient. So I think the best way to know what is going on in there is to do an endoscopy. So yeah, maybe Joseph, do you have?
Yeah.
Okay, so yes, someone has. I saw a comment there that the MCV is high. Of course, the hemoglobin is 7.3. With Joseph told us that the baseline is around 9, and but with this MCV, so if your machine is like most the normal range of the, we talk about roughly 80 to 100. So 101 just slightly elevated. So there are things like B12 deficiency and many other things, but I think this is mildly elevated, and therefore I wouldn't spend a lot of time focusing on that. But if there is any other thing to learn from that, I think Joseph, I'll be ready to learn from Joseph later. So do you have any other investigation, or should I commit at this point? But I think I would need an OGD to see what is going on.
Mm.
But I know probably you will need me to commit before seeing the results of the OGD. So how do you go about it?
No, not really. So yeah, he said he had, I think, dialysis a day before he had this episode of vomiting blood. That's what I remember. And so when we were stricken by this creatinine, he said that's normal. Usually 400, 500. They do dialysis to me, but that's what happens. So let's see. We had other investigations, and you asked for. So he received pantoprazole, the AED, octreotide, ceftriaxone, IV fluid, and was admitted in the ward. And the vomiting didn't recur in the ward on that day. Next day, he did an OGD, which showed normal findings. And so he was discharged home, but he had another episode of vomiting fresh blood at home. And he was taken to another center. They repeated OGD and also showed normal findings at that center.
Okay, this is getting complicated, and uh, 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 thank you for the comments in the chat. Of course, this is very correct that an elevated BUN can be a result of upper GI bleeding. Yes, when you have upper GI bleeding, the BUN can be elevated. So I think that was a very good observation. Now OGD has been done, and it's completely normal. So we are dealing with those causes of again. I think there's a very good term for that one. So you do OGD. OGD is normal, and the patient is presenting with episodes of vomiting blood. So that is getting complicated, because if we were talking about something, for example, gastritis, So definitely, at least they would have seen some hyperemia there. If we're talking about an ulcer would have been picked by the OGD. So we are dealing with vomiting, and then OGD is non-revealing. So what is going on? Now I think that is a topic because I have not come across such a challenge before. I think I just heard about this term, which is also flying away from my mind. But I think that there is a very good term, and maybe Joseph, if you know that,
Obscure.
you'll tell
It
us.
was called obscure.
Yeah,
Obscure
yes,
GIP.
yeah. So you are dealing with you are dealing with obscure bleeding. So with this, maybe so what I could say is you have an episode of upper GI bleeding or GI bleeding in general, and this is upper GI bleeding because the patient is vomiting blood. So you are and you see nothing on scoping the patient. So maybe it's so bleeding from an area where an OGD cannot reach, or maybe you have a lesion which the OGD cannot see. So as I said, if we're dealing with gastritis, we would have seen something. If we're dealing with an ulcer, we would have seen something. But OGD is negative, and I should say this is a topic I ran away from because I've never come across causes of obscure upper GI bleeding. So all the differentials that I had, I talked about a possibility maybe because of the anticoagulants, because of the antiplatelets, because of uremic gastritis. All these are negative. So what exactly is going on, I do not have. So today is one of those days where I do not exactly have um, an idea what is going on with the patient. So is there something else that can help me make some progress?
So, so what are you doing? Y- a story like this, what are you telling the patient, or what are you helping? Maybe if you can further uh, get get ahead in terms of the diagnosis.
Okay, so I'll go back and to today is a good day because I'm getting some help in the chat. So uh, mouth examination, are there mouth lesions, KS? Joseph did not tell us anything of that sort in the HPI, and of course when he examined the patient, he did not report any abnormalities in the oral mucosa. And as I said earlier, that when a patient presents with upper GI bleeding, the very first thing that I'll try to do is to clarify if I'm dealing with upper GI bleeding really, or if I'm dealing with something else. And this something else could be hemoptysis with the patient swallowing blood. It could be epistaxis and the patient swallows blood. It could be a tooth extraction, for example, bleeding in the oral cavity, and the patient swallows blood, and the blood will come out later after irritating the stomach. So we did not have such clues in the history, uh, as well as on exam. At least Joseph didn't tell us anything about that. So maybe this is a point to go back to the patient and clarify those details in order to see if we are not dealing with bleeding from another site, and then the blood gets into the stomach and then it's vomited back. So like examining the nasal cavities, asking the patient about epistaxis, asking about coughing up blood, and then of course, if there was any recent tooth extraction, wouldn't expect the patient to bleed and then they go home and then they bleed again. But it's important to clarify those details.
Mm.
But then apart from that, So those mimics, apart from the mimics, then we go back to the GI itself. So what could present with upper GI bleeding and then it's not visible on endoscopy? I do not have an answer to that question. So I would make progress by going and reading about causes of obscure upper GI bleeding. So I know there are some technologies sometimes when they come across, so in settings where resources are, where there are resources, if they come across challenges like this, so they can do, so there are pills. Someone swallows a pill which is basically a video. So that goes down, and then later on they can look at it and see some other sites which are not reachable by endoscopy, by upper GI endoscopy, and yet could be a source of upper GI bleeding. Because many times when an upper GI endoscopy is done, uh, most commonly they will just go a little past the pylorus, maybe into the first part of the duodenum, but not into other parts of the upper GI, which could explain upper GI bleeding. So maybe the bleeding is coming from a site which is not reachable by endoscopy, or the patient has a lesion uh, that is not visible to endoscopy, or we are dealing with the mimics that I just talked about, or maybe it's something else that I'm not aware of and that I will read today. So what I would do is maybe just go back and read about causes of obscure upper GI bleeding and see if I can help the patient from there.
Yeah, sure. Roland is asking how long has he been on a clopidogrel? Is for quite some time. I think maybe a year or something. So yes, David, and sure. So that's what we also did. We went back and asked this patient, and he said a day prior he saw blood coming out of his mouth, and he would spit it, and some came through the nostrils. He thought it was coming from an aching tooth that he had. Did that change anything?
Yeah. So yes, very much. Like I said earlier, so that would be the very first thing to do if you are taking history about upper GI bleeding, because the patient uh, could be coughing up blood or blood from a tooth, or having a nosebleed and they swallow blood and it irritates the stomach, it comes back up. So yeah, that changes a lot because endoscopy was done. It's normal, so I think that is the closest possibility that we have. So it could be that the patient swallowed blood and the blood came back up after irritating the stomach.
Yeah, so we took this patient to an ENT to be examined, and he did an anterior rhinoscopy. He didn't see any blood or bleeding or clots in the nose. He only saw hypertrophied inferior turbinate, and the throat exam he saw grade 2 tonsils and blood stain on posterior pharyngeal wall. So his provisional diagnosis of allergic rhinitis epistaxis, but he said still you have to rule out you upper GI bleed. What's your diagnosis?
Okay, so my diagnosis, I'm thinking. So for this particular patient, of course, I'm not very comfortable with. I'm not very comfortable with the closest the possibility that I have. So I think, of course, at this point in time, I'll just uh, uh, I'll just examine the patient's oral cavity. So the ENT surgeon did a rhinoscopy, and then of course he went all the way to the tonsils. So I'm thinking maybe the closest possibility, of course, is that this patient was either having a nosebleed, or most likely that, and then he swallowed the blood and vomited it back. But I think that will not make me relax. That will be my working diagnosis, and then I'll go and read more about some causes of upper GI bleeding that would be missed on endoscopy, and therefore and see anything that is uh, that is uh, that is in keeping with this patient's presentation, the given his medical history, the issue of CKD. I'm seeing a lot of suggestions here, like Delafoy lesion, which can be missed on first OGD, angiodysplasia, uh, which is common in patients with CKD. But then, so I'm thinking, because some of these lesions we read them or we talk about them as differentials, but I believe they are not as common as the commonest causes of upper GI bleeding that we see in our settings, which are peptic ulcer disease, variceal hemorrhage, and maybe low on the list will come other things like Mallory weight tears and others. So for something like angiodysplasia, I'm not sure if they would have missed that on endoscopy. So I think I'll entertain the possibility of that this patient is bleeding maybe from the nasal cavity, oral cavity, and he missed that. But I'll keep searching for other possibilities.
Yeah, sure. So I think we are on the same line. So based on the blood stain that the ENT saw on the back of the pharynx, the closest that this could be was a posterior epistaxis with blood trickling down the stomach, irritating, and then it would vomit it. And sure, this was true because these two were not the only vomiting blood that this patient had. Later on, he presented again to the hospital. Now he had vomiting blood, and he had epistaxis that he initially there was no blood coming out from the nostrils, but when he came I think the third time, it was there was blood like on the nostrils. So it was a posterior epistaxis, and we'll learn a bit from it. So let's see what happened first. So GI Nephro advised the clopidogrel heparin, which this patient used during dialysis, as you said, to be withheld, and he no more bleeding happened. But the ENT recommended that this patient has to be sent for nasal endoscopy because he said the anterior rhinoscopy that he's doing cannot see on the posterior part. If this patient, which is highly likely, had a posterior epistaxis, there could be causes, and maybe it's a malignancy, who knows? So it has to be seen. So he was advised to go for nasal endoscopy to determine the cause, and also they provide management. Maybe you need cauterization. But this patient, when he saw the bleeding stopped, he deferred that consult with the NT, and yeah, he's just I've seen him for like 2 weeks. He didn't have any more bleeding because he does dialysis at the same center. Yeah, so I've never seen this. So this was my first case. But when I talked to the NT, he said, "Oh, this is normal. We have been called multiple times with this patient like this. They vomit blood, GI do stuff, but they don't see anything. And then we see it's a posterior epistaxis. We pack this patient. If it's impossible, we take them to the theater and cauterize the arteries." He said most of them turn up to have pathological causes, especially malignancies, early malignancies of the posterior part of the nasopharynx. So yeah, this was the case of the day, and I think we have some few teaching points here, as you discussed. Upper GI bleed, very common thing. So you have the common causes and rare ones, as you said, exactly. Peptic ulcer, varices, esophagitis, the common causes, but we have some rare causes like Mallory ways, tumors, Cameroon lesions, the diploids, gastric anterior vascular ectasia, AVMs, hemobedium or Sacus pancreaticus, a lot of them. So the term obscure GI bleed now has been changed. It is called small intestinal bleeding. The obscure was used when they didn't have the pill endoscopy. Now, if they give someone pill endoscopy, they will see, and most of these will come from from this small intestine. But if you read about them, they are less likely to present with vomiting blood. They will present when maybe someone has anemia. They do stool forecast blood, they see blood, but they don't see, they do an endoscopy, they don't see anything. Or they have, if it's brisk, they will have like hematochezia. But vomiting blood, truly something has to be above the ligament of Treads. And if not, now you have to search for other things. Maybe you have to repeat endoscopy, for example. Maybe someone can miss neuropathic lesions. But this patient, it was done by two endoscopies and still it was negative. So some few teaching points on epistaxis can be anterior, which most common is anterior epistaxis that even some of us have had this throughout our life, which is self-limited. 90% of it will occur in Kurzebach plexus, as you can see here. Some very nice vessels coming together, forming a plexus, as you know it. This is usually self-limiting when you pinch your nose. And then the topic of today, the posterior epistaxis, which mostly come from the sphenopalatine artery. This causes significant hemorrhage to the extent of causing anemia of this patient, like 2-3 points drop of his HB, and it requires an ENT consult. So, regarding this patient going to another hospital, when he came to my hospital, I realized I have to send this patient to a hospital. I have 24-hour ENT, but those guys, when this patient went there, they also thought of GI bleed. They did an endoscopy. So I realized, okay, if people can miss this, I have to present this, David, and we can all learn from this. So it can present as a pseudo upper GI bleed. I googled about case reports and I saw them patients presenting with GI bleed, but turns out they have the posterior epistaxis. It's easy when they also have blood on the nostrils, as you're seeing on the anterior nostrils. But if they don't have, everyone will think it's just a upper GI bleed and take them to endoscopy. Treatment, this requires ENT, I believe, and they do balloon or Foley catheter. They put it and they balloon. It compresses the bleeding, like they say for 48, 72 hours, they remove it. If it doesn't, they take this patient to the theater and cauterize the arteries. Also, they can do cotton packing. I was told it's different for packing that we can all do that from the anterior nosebleed that doesn't respond to nose pinching. So this was the simple case of today. These are risk factors: anticoagulation. This patient was on heparin, breathing diseases, nasal malignancies, use of aspirin. There's no clopidogrel was mentioned, and alcohol. Yeah, maybe we can hear from you, David.
Thank you very much. So I'll just spend a few minutes, maybe a few seconds, on reflections because we I think we have someone who needs to share about a case of upper GI bleeding in an dialysis patient. So uh, thank you very much, Joseph. This was you see, cases of upper GI bleeding, like I said, I think they are common. I believe many of us here have come across cases. Maybe if you are not primarily responsible for taking care of the patient, but at least you clerked them for a bedside or for an exam or something like that. They are common cases, but then so sometimes I think what today's case has taught me is to leave that saying that we keep on saying every day, that you should be broad when you are clerking patients or when you are taking a history, because if you hear upper GI bleeding, it's like a reflex, peptic ulcer disease, variceal hemorrhage, those common causes. But then we read that from books. That of course the first thing is to clarify if you are dealing with upper GI bleeding or something else. And I think that was in my first 2 or 3 sentences, and yet I think it was until the very end, after I was stuck, after an OGD was done and it was normal, so I had to go back. So I mentioned the very same thing, but then it was not part of my considerations, just because you did not tell us in the history or in the exam that you saw something on the oral cavity or the nasal cavity. So it was an important and a very good learning experience. Thank you very much. So I think we should straight away welcome Hadawa to share the case of upper GI bleeding in a dialysis patient. Karibu sana.
Asante. Mimi Dr. Huda Akrabi toka KCMC ni nephrologist. Okay, so I saw this forum. I think I saw the link in Afita or Mat group and I just joined, but I'm not sure. I don't know like about this group. Anyway, the case I want to share is I think 2 weeks ago, we had a patient who is hypertensive with CKD on dialysis, and she was on nifedipine hydralazine, but not on any antiplatelets. So suddenly the patient developed severe upper GI bleeding, like she vomited 750 mils at once. And my registrars were like running with her to the endoscopy unit. And luckily I was there. So I scoped her and I found blood all over the GI, like in the esophagus, stomach, duodenum. So I managed to flush the blood from the stomach and duodenum, and it was clear. There was no ulcer and there was no focus of bleeding. Now, when I was coming out, I saw a lot of fresh blood coming from the esophagus. So I realized that the patient had esophageal ulcer. So what I did is at that point, and it was like up, I think 22 or 23 centimeter. So I just injected adrenaline to stop the bleeding, but I was really surprised why she get an ulcer. Anyway, we admitted her for observation and we kept NGT for draining to see if she will continue bleeding. She did not continue bleeding, but after 2 days, she developed a lot of mouth ulcers and toxic epidermal necrolysis. So the presentation of the toxic epidermal necrolysis started as an esophageal ulcer, then she developed the skin reaction. So we consulted dermatology to know like why she got the 10, and they thought of nifedipine as a trigger. But when I went to look at the literature and I saw some case reports mentioning that hydralazine in dialysis patient can trigger 10. So we stopped both the nifedipine and hydralazine and we started her on other antihypertensives. She's still admitted and we are still monitoring her, but I thought it's an interesting case because she presented with upper GI bleeding before the skin reaction. Thank you.
Oh, thank you very much. Thank you very much, Doctor. That was a very interesting case, and I believe I'll speak for myself. I think that is something learned today. So an esophageal ulcer, I believe I'm not sure about everyone else, but when I mention causes of upper GI bleeding, I almost never mention anything about esophageal ulcer. So that's something that I've learned today. Thank you very much, and thank you very much for joining. So we are here almost every Sunday, and we send the links in many groups. One of them being the Afita group. So please keep joining us, learn with us, and share your insights that will be of help to many of us. So this is a group that the only thing that is common among us is that we're all interested in clinical reasoning. It's a very diverse group, so there are medical students who join here, there are interns, there are residents, there are physicians, specialists, as well as super specialists who join sometimes. So we will be very happy to have your constant attendance in order to learn from you and learn together. Thank you very much and welcome.
Thank you.
Yeah, thank you very much, Dr. Dao. And it's a pleasure for us to have someone like you. You're a super specialist. Most of us, yeah, are physicians, residents, maybe medical students. So if we hear some teaching from you, that's pretty impressive. That's why we started this, to learn. And yeah, also I should thank the audience. There was a lot of teaching also going on in the chats. One from Kisoka who said he thinks the high MCVs from use of airpoint dialysis. That's pretty good teaching point. So we keep learning from that. Um, I should also thank every one of you. And David, if you don't have anything else, I think we should meet next week.
Yeah, sure. We meet next weekend, and maybe next weekend I hope just to prepare people, I would like to have. I'm not sure who will be presenting. That could be me or Joseph, but whoever is presenting, I'm looking forward to getting a co-discussant. So if I'll be discussing, I'll be happy to get a co-discussant next weekend. And if I'm presenting and Joseph is discussing, I believe it's the same case. So that I believe I myself, I think I would like to learn from someone else discussing a case. And so next weekend, I hope we'll have volunteers and maybe pick someone who will be comfortable discussing. So uh, be prepared for that. And in case anyone wants to discuss right away, you can just reach out to me or Joseph to show interest, and maybe next time discuss yourself. That will be very good to learn from you. So thank you very much, everyone. And if there is nothing else, have a good night, and see you next weekend.
Good night.